So this is lab and imaging studies for the surgical patient. This is to go over certain labs and imaging in case you've not had this material before. So when we talk about it in surgery, you have a rudimentary idea of what's being discussed. So the first test is a complete blood count CBC with a differential. This measures the hemoglobin and hematocrit. The CBC, the hemoglobin and hematocrit goes down in anemia and with trauma when you have blood loss. With severe blood loss, if it happens quickly, the body doesn't have a chance to re-equilibrate the levels, and if you take a blood check, you'll have a normal hemoglobin and hematocrit even though you have severe blood loss. If you give fluids, normal saline or Ringer's lactate, and it dilutes, hemodilutes the red blood cells, then that's when the blood test will show a lower hemoglobin and hematocrit. You have the white blood cell count and differential, platelets, the reticulocyte count, and immature red blood cell count. Shows immature red blood cells. So if you have a lot of anemia, then your marrow will kick out more of these immature red blood cells, even though they're not ready because they're needed in the body to carry oxygen. With the white blood cell count with differential, it can be increased or decreased in number. It increases with infection. With the you'll have what's called a left shift with when you have an increase in infection, which means you have more neutrophils, and you'll have an increase in your bands, which are immature white blood cells. So these are the different types of white blood cells, and the erythrocytes are there just to show you the size of them. So there's the band neutrophil, which is an immature cell. There's the normal segmented neutrophil, so the band is, again, an immature neutrophil. Lymphocytes, it's the second most common. Monocytes, basophil, because of this basophilic stippling, this coloring, these dots there, and then the basophil. So these, again, mature neutrophils, and they go into the band, so the more of these you have, the more serious the infection is. This is the old differential count that they would use. So the neutrophils would be over here. So each time the medical technologist would look in the field, they would click on this, and they would click on, and then it would measure the total number over here. So when it got to 100, that would measure the percent that they would see in the field. So they would look through several fields. Now it's automated. So this is done like this. Now, if you go back, the neutrophils are over here, and I believe, let's see, I think actually these are the neutrophils here. So they would talk about a left shift because over here you would have other cells, but you would have an increase, so they would talk about a left shift. So if you see that in a clinical scenario or a question on a test, and you say the patient has a left shift and increased white blood cell or neutrophil count, that's what's being talked about. Other tests that you can order are the comprehensive metabolic panel. Many of you have talked about that in your group submissions for your problem-based learning. So one is the BUN and creatinine, the blood urea, nitrogen, and creatinine. Both of these measure kidney functions. There are some drugs whose metabolism are affected if you have a decreased kidney function, and CT contrast, CAT scan contrast, which is iodine-based, that can cause a problem with kidney function. So before ordering a CT scan with contrast, many hospitals require a BUN and creatinine tests. The electrolytes, an increase or decrease, can cause weakness or excitation, depending on which ones are up or down. You can have EKG and heart abnormalities. Again, all of these will go through in different scenarios in hematology and pathophysiology, but potassium, sodium chloride, and calcium are some of them. Magnesium's not routinely ordered, but you can order that as well. It's a good one to order as well. So any electrolyte abnormalities can cause problems with weakness or excitation and can affect the well-being of the patient. The other parts of the CMP or the liver function tests, this is actually a misnomer. It actually assesses liver damage. These ALT and AST, the alanine transferase and aspartame transaminase. These actually, when those go up, it indicates the liver cell damage. The true liver function tests are the prothrombin time and the albumin. Those are chemicals and proteins that the liver manufactures. So if those are decreased, it means there's a problem with the liver function. Alkaline phosphatase is a non-specific. It increases with bile duct obstruction and bone metastases. Also included in the CMP is the bilirubin. You get a level of the total, and then the unconjugated or indirect, and that's pre-hepatic. So these are the unconjugated bilirubin is formed from the breakdown products of the hemoglobin. It's not water soluble. It's increased in hemolytic anemia, which makes sense. If it's formed from the heme, then you would have an increase with hemolytic anemia. In liver disease, because it's not processed, so again, this is pre-hepatic. And then conjugated means that it's processed by the liver, it becomes water soluble, and it's increased in gallbladder disease because that's what is in the gallbladder when it gets stimulated and contracts. So if you have problems with the gallbladder not contracting well, or if you have a stone in it, you'll have an increase in the conjugated or direct bilirubin. BUN, blood urea nitrogen, we mentioned that ahead of time earlier. It's a renal function test. It can increase without an increase in creatinine, with increased protein digestion, red blood cell ingestion with a GI bleed, and steroids. The creatinine is another renal function test that's based on the renal clearance of normal muscle breakdown. There's an inverse relationship with renal function, so as the creatinine goes up, it indicates decreased renal function. So Dr. Cleveland talked about having an increase in creatinine and your urine output related to shock. Both increase with age due to decreasing renal function. Proteins and other tests that will be on the CMP, so it includes albumin and globulin, which is the total protein. Albumin, again, we talked about, it's reflective of poor nutritional status. Now that's long-term. A short-term test would be the pre-albumin. That's not routinely ordered in a CMP, but you can order it. The albumin is decreased with liver, kidney, and autoimmune disease. The globulin is also reflective of nutritional status, increased in certain diseases like blood cancers, rheumatoid arthritis, kidney and liver disease, and tuberculosis. So if you have a abnormal BUN and creatinine, and they're both elevated, you can see if it's related to a pre-renal cause or dehydration. So if you check the ratio, BUN to creatinine, and it's greater than 20:1, it's usually a pre-renal problem or dehydration. So, and if it's less than that, it's usually a renal cause. So we'll look at that in a lab, upcoming lab here. Other labs that you can include in there, which may or may not be on the CMP when you order. It depends on each lab and each hospital how they do it. There's a serum amylase and lipase that's increased with pancreatitis. So I had a friend who went to the hospital. She was having vomiting and I think maybe diarrhea, and there was a virus going around in her town. She was up in Washington, D.C., so everyone was coming into the hospital. And the doctor was astute enough to order amylase and lipase, so they found out that she didn't have acute gastroenteritis, she had pancreatitis. So good thing for the doctor and her, so because the treatment is different. Another test is a prothrombin INR. That means the international normalized ratio. It monitors warfarin therapy, which is a vitamin K antagonist. It binds up vitamin K, and it's used for as an anticoagulant, and it assesses liver function as well, the PT. The activated partial thromboplastin time monitors heparin therapy. So those are two different ways to monitor clotting when they measure different things. So looking at a set of labs that you'll see, so in this person, this is actually my lab. So my white blood cell count is down a little bit, I don't know why. And you'll see that you'll always have a normal range, so you always get to see when you're ordering labs, in case you forget what a normal is. I mean, there's a lot to remember. So in case you forget what a normal is, you get an idea by looking at the range there. And each lab is a little bit different, so you always have to look at their range. So red blood cells, normal, hematocrit, what else is down here? Okay, so the platelet count is fine. This you don't have to worry about now until you get to hematology. These are a measure of how big the cells are. These are all very similar tests, and the cells are normal. Again, it's not something to worry about so much with surgery. So here, there's two sets of white blood cell counts, either the absolute neutrophils, because if you counted 100 cells, you might have a decrease in all your cells or an increase in all your cells, but the percentage would be, would show in a particular way. So it's good to see the absolute number as well as the percentage. So again, more lab values. So cholesterol, a little bit up. Mine's down now. HDL, these are labs that you would order. Not so much of a concern for surgery. Glucose is important. There's the BUN and the creatinine. And then the glomerular filtration rate, that's not always calculated. BUN creatinine is not applicable because the creatinine's normal and the BUN's normal, so they wouldn't normally check the BUN creatinine ratio. Sodium, potassium, chloride, carbon dioxide, calcium, that's another test. I didn't actually include that, or actually it was. So you can look at the normal range there. Total protein, albumin, globulin, the albumin-globulin ratio, total, indirect, direct bilirubin, alkaline phosphatase, AST, ALT. So pretty normal. This is something that you'll see when people write notes with the electronic medical records. It might be used less, but this is called a fishbone way of writing out the CBC and the electrolytes. So the white blood cell was here, the hemoglobin, hematocrit, segs, bands, lymphocytes, monocytes, basos, eosinophils, MCV, MCH, MCHC, and platelet count. So again, if you see this is what it indicates. You can put a copy of this. You can get this off the internet and put it into your smartphone. Again, the fishbone notation for sodium, chloride, potassium, bicarbonate, you can put that down there. And then they can also add the BUN, creatinine, and glucose. So again, these are just an easy way to show this. This is a wound culture. So they have it right here. The source is the right thigh wound. And this shows out the bacteria. So this is preliminary. Usually it's done in 24 to 48 hours, and then the final. So they'll call the lab initially and say, how's the patient doing? Especially if they're very sick, they want to know, well, has anything grown out in 24 hours? So it looks like this, and then they do other microbiologic tests. So the final was Staphylococcus aureus. So then you go down here and you say, what's sensitive, right? Not quite sure what this is. This might be the minimal zone of inhibition or the minimal inhibitory concentration. But it shows here what's sensitive and then what's resistant. So you don't want to use the penicillin. And this lab is great enough to tell you which one, how much it costs per day. So you can actually order the cheapest one depending on what is going on with the patient and if it's an oral or IV antibiotic you want to use. Here's a urinalysis, and again, you'll have usually have normal. So we'll have to take a look at this here. So the color is straw, which is yellow. That's normal. Cloudy, it should be clear. Glucose is negative. Bile is negative. Ketones, which is increased with diabetic ketoacidosis. Specific gravity looks a little bit low. pH is acidic, which is normal. It's supposed to be slightly acidic. Negative protein. There's some urobilinogen. Nitrites are negative. The blood is large, and the leukocytes are large. Nitrites is another chemical test for leukocytes, but they did another chemical test which shows it's increased. So then when you look at the urine, red blood cells are up. So the normal is 3, 4, 4.3 for females because a little bit of difference. And the white blood cells, there should be hardly any, 3 to 6 with females, and they have 70. So this indicates they've got a urinary tract infection. They've got some red blood cells, which is also indicative of this. Epithelial cells, there should be 0 to 2 or 0 to 4. And if there's an increase in epithelial cells, that means it wasn't a good urine catch. It means the urine hit off maybe the walls of the labia and brought some epithelial cells in there, which also means it brought in bacteria. So that wouldn't be a good specimen. The specimen that they like to use is called a clean catch. So if it's not a good clean catch urine, it would show because it would have more epithelial cells. No cast, lots of bacteria. They looked at this microscopically, so this is indicates a urinary tract infection, UTI. And here's what a urine culture looks like. So again, they've got moderate growth of yeast, Pseudomonas, and E. coli. So E. coli and Pseudomonas are common urinary tract pathogens. Not really sure why they're growing yeast. That could be it could be a contaminant, or it could be that they're actually growing yeast. So this was done for the bacterial infection. The yeast would have to be, they would have to do a separate culture for that, because none of these would cover yeast infections. But again, you can see which ones are sensitive or which ones are resistant, so you choose a sensitive one. And this is an intermediate, which is also not a good choice. You want to get something that's definitely sensitive. So ampicillin would be a good choice. Piperacillin, tazobactam, that's very expensive. That's an IV drug, I believe. So in this, well, actually it's amikacin. So it's not going to be very easy to treat this person. Okay. Arterial blood gases. You'll receive this. You'll get this again when you do respiratory and pulmonary. But again, a preliminary review. The normal pH in the blood is 7.35 to 7.45. That's, again, lab dependent. The oxygen level is 80 to 100. The carbon dioxide level 35 to 45. And the bicarbonate is 24 to 26. So let's take a look at this person's lab. So the sodium looks okay. Potassium way up. And that's going to show problems on an EKG. The chloride is normal. The urea is up. Now this is taken from England, and you can tell because of the way they spelled hematology with that A in there. But this, the equivalent of this would be 2.6. So normal in our American system would be 0.70 to 1.20. Using they're using micromoles, so in millimoles it would be, I believe, 2.6. So they've got renal problems going on, and trying to look at this B1, that doesn't look quite right either, because usually maybe, oh, that is right, that's correct. Okay. Then the hematology, the hemoglobin, again, that would be 12, so that's okay. Normal is 13 to 18 for this person. White blood cell count is up to 12,000, not terribly up, but it's up. Platelets are decreased, so they've got thrombocytopenia for some reason. Look at the pH, it's very low, so this person's in trouble. Their PCO2 is within the normal range. Their O2 is down, so they're hypoxic. Their bicarbonate is decreased, so they're in acidosis. And the bicarbonate goes down when it's trying to compensate for the acidosis. So they're in severe acidosis. They've got a low pH. They're losing their bicarbonate. Glucose is little bit up. And again, I'm not sure that they're using a different value from ours. And the lactate is way up. So you know Dr. Cleveland talked about the lactate being greater than 4. So they're in a lot of trouble. This is a really abnormal blood gas and lab values. So they're probably not going to make it. So let's talk about X-rays. Plain radiographic film uses X-rays harmful to the fetus and increase of risk of cancer over time. That's why it's always important to get a beta HCG. Figure this out, beta HCG, to check in the blood. The urine is usually positive after a week or 2, but I mean it's better to get the serum because it's more accurate. Okay, to check for pregnancy. These are the normal markings in an EKG. In a chest X-ray. So you have the trachea, the right main stem bronchus. You can just barely see the left over here. Sometimes it's not clear depending on the image that you look at, if it's underexposed or overexposed. There's the aortic arch, pulmonary arteries on both sides, the right atrium, diaphragm, stomach, and liver. Sometimes you can see the air bubble right here. Left ventricle, this looks like a normal chest X-ray, and again, these are normal chest X-ray. If you go back and forth, you can see this. This is gas in the intestine here, that's normal. Lungs look nice and clear. Pulmonary vessels. This usually indicates a vessel that's looking at you. So instead of the vessel going like this, as you see down here, the vessel's facing right at you. Okay. Sometimes it's hard to differentiate that, so if it looks abnormal or someone's concerned or they have symptoms on that side, then a CT scan will be ordered. This is a BUN, or also known as a KUB, kidney, ureters, and bladder. So you can see the different markings here. There's gas in the GI tract, sacroiliac joints. The things we're more concerned about here in surgery is just the way that the abdomen looks. So, but it's always good to look at all of the different markings in the X-ray, even if you're just looking for one particular thing. So this is a normal abdominal plain film, or KUB. There's a lot of gas and feces in the intestines here, but other than that, it looks normal. These are air fluid levels, and this indicates obstruction. So if you lay the patient, if the patient's laid on their side, the air fluid levels will level out in one area. If you stand the patient upright, then the air fluid levels show in a different level. So when you order the abdominal X-ray series, you can have them on left lateral decubitus and upright if you suspect that they have a obstruction. These are C-spine X-rays. Dr. Cleveland was talking about the 3 different views. So the 3 views that they were talking about were an AP, that's anterior posterior shot, and then a lateral. So that's what they look like. So you can look at these markings here. You'll have all of this in radiology, but again, I just want to give you an overview. You become more expert at it. And this has, you can just take a look, and all of the vertebrae bodies look good. The spinous processes, everything looks fine. The space in between looks good, and again, it's a normal curve, as they say in the X-ray. So this is a C-spinal oblique, so sometimes you can see other fractures here that you wouldn't, but that's not the view that he talked about. The view was the odontoid view. I'll show you that in a moment. This is the C-spine fracture, so they've got one here, looks like, go up here, 1, 2, 3, 4, 5, 6, 7. So that's you can see the irregularity here, and all the arrows are pointing there. This is a anterior, there's actually, there might be one here, and I think there might be one here. I don't know what that is. Definitely here. So they've got some significant trauma, so they may or may not have spinal cord injury with this. mean, the vertebrae itself is not in the spinal cord area, but still significant trauma and swelling. So this is the other view that Dr. Cleveland mentioned. So it'd be apolateral and the odontoid view. This is taken with the patient's mouth open, and you're looking at the odontoid process. Here it is fractured, right there. So that's why you order that kind of X-ray. Get the fracture right there. Pelvic X-ray is another X-ray for trauma. So this is a 35-year-old male. Looks good. Joint looks good. His pelvis looks all lined up here. Don't see any signs of fracture. So this is a severe hip fracture. You can see the spaces between the ilium and the ischium, and the rami here are greatly separated. Here is a less discrete fracture. There's some space between the two sides of the hip, so they've got a little dislocation. You might have another fracture up here, so it can be very subtle. So you'll have more radiology with Dr. Armstrong in the summer. So ultrasound, Dr. Cleveland talked about this as well. It uses sound waves which translates into a visual image. So on the abdomen, it's a focus assessment with sonography for trauma. And again, there's 4 views that are used. And this is a good screening, and it's also a quick way to do an assessment. It's not 100% accurate, but it will show if there's any issues going on with the patient at that moment that's emergent. And if that's normal, then sometimes they'll be sent for a CT scan or an MRI, again with someone to be with the patient in case the patient becomes unstable. So there's also arterial ultrasounds that can be used. They can visualize if there's a problem in the carotids or the abdominal aorta. If that looks like there are symptoms of the aorta increasing in size or getting ready to rupture. It can be visual and auditory results that you can get. So this is what the abdominal ultrasound looks like using a FAST. So that's a transducer, and they would put it in different parts of the body. This takes some time and technique to use, and usually as a PA you wouldn't be doing it, but you might if you work in the ER, and they usually have an ultrasonographer doing the test. They come around and order the test for you and read them for you. So here's an example. Again, this takes some orientation, but there's blood here in the abdominal area. There's the liver, more blood, the kidney, and the lung. And again, depending on where the ultrasound is, it's like taking a picture with a camera. You take the front of the head, the back of the head, the side of the head. So the same thing. So the sonographer would orient the person, you, and tell you where it is in relation to the patient. But it takes some time and skill to learn the different parts of the body when you're using that. Here's a photo of the abdominal aorta and then the iliac arteries coming off. Here's a photo of the carotid artery bifurcation. So again, these can be colored enhanced, and you can also hear the flow. It makes a sound when you put the Doppler up against the patient's artery. So a CT scan is the computerized axial tomography, or sometimes they call it a CAT scan. That's where that came from. It's digitally radiographic images, digitally reproduced. So this is done with computers, and they have an array. So if you ever have had a CT scan, it looks like a semicircle. The bed is there, and they have all of these different X-ray arrays, and so as the rays are shot and these call them cameras or electrodes, they pick up the X-rays, and then they digitally reproduce them, and they can make them into cross section or frontal views. There is an increased risk of cancer with CT scans, and again, you have to put this in the proper perspective. If someone looks like they're in acute distress and they might need to have surgery, you have to have a slight increase of cancer just to save the patient's life. So again, for routine, some people are opting for an MRI, which doesn't use radiation. It's more expensive, and the insurance doesn't always cover it. But you can order it with or without contrast. The contrast enhances the view of the blood vessels of the GI tract. But again, you have to be careful with renal damage if the patient's diabetic, and you order a creatinine and a BUN just to be sure the patient's kidneys are functioning fine. You can give isotonic bicarbonate to decrease the nephropathy risk. So this is a image of a cross section of the CT scan at one particular level. So you can see many of the organs here. You can see the livers over here, gallbladder, stomach. There's the air bubble right there. The pancreas, some of the intestines, the left adrenal gland. You've got the left and right kidney, the spinous process, the aorta. So there's a lot you can see here. Here's the ribs. So the X-ray, it appears as if you're looking from the bottom of the patient's feet up to their head. So that's why that's the orientation of the view that you would have. So let me see if I can go to this. Oh, this is actually for the CT scan for you to view. So it's about a 4-minute CT scan, and you can, let's see if I can start from here, slideshow. That was going to do that to me. There. So view that on your own. The MRI is a magnetic resonance imaging, and it uses magnets to create images. So they're considered to be safe, even though there is some body effects to magnets. They're using them now for depression. They use magnets to heal fractures that don't heal on their own. So they have some effects on the body, but so far there hasn't been any negative effects. There can be no metal in the patient because of the magnets, and so that can severely affect the patient, especially if you have a foreign body someplace. It creates cross-sectional or frontal slices, and again, these are digitally reproduced. It can also, in some cases, produce 3D images, so that's really great to see. And unfortunately, the imaging itself causes jackhammer sounds. It's really loud, and for some patients, it incites claustrophobia and anxiety because you have to be put into a tube. So you might see some imaging centers, they'll advertise an open MRI or open CT scan. And so those are ones that they have the detector or rays in a way so that it's more open, it's not closed space. It's a little more expensive to do. So this is what I wanted to show you. Get it to work here. So this is a MRI, and again, you can watch this on your own. So this is starting from the back of the patient. So you see the patient's muscles. So right there, you can start seeing the liver and the spinal cord. I believe these are the kidneys, the psoas muscles. See the spine there, more of the liver. Starting to see some of the intestine. Looks like the part of the hip. Liver, what else is here? Looks like a male. There's the bladder. The heart comes into view. Looks like the spleen is starting to show up. Some of the intestine, a section of the intestine. Okay, so you can view that on your own and take a look at that. And again, it takes time to learn how to read those. Other tests are upper GI series. These aren't used as commonly as a CT because the CT scan and the MRI are so good, but sometimes they're still used. It's used to visualize different parts of the gastrointestinal tract, especially for the esophagus. So if people have a problem with swallowing, they have dysphagia, and they do an endoscopy where they put a fiber optic camera into the esophagus and look inside, everything looks normal, then they might do have the patient swallow contrast to get an idea of how the peristaltic movement is in the esophagus. So they either swallow barium, and these are radio-opaque contrast, or gastrographin. And gastrographin is the trade name for diatrizoate, and it's just easier to say gastrographin. These are water soluble, so in case there was a fistula or there was a suspected rupture someplace in the GI tract, then if the contrast material went into the abdominal cavity or the lung cavity, it would cause less inflammation. So then a series of X-ray images are taken. Again, for swallowing issues, if something's not visualized by a CT scan or MRI because it's so small and it wasn't detected, and if the patient has reflux symptoms, and then that can be visualized functionally to see what the stomach and the esophagus is doing. Crohn's disease is an inflammatory condition of the intestines. So part of the intestines may be scarred, or any place in the GI tract could be scarred. And so again, it shows these areas that may not be visible on a CT scan or MRI. Here's an example of a ileocecal fistula, and there's the fistula here, and again, this is supposed to be a part of the intestine, and it's scarred down. Instead of having a wide lumen like this where the barium is, it's scarred down, so the barium has a difficult time getting through. This is the stomach with an antral narrowing, and then there's two duodenal strictures, and then the small intestine doesn't look completely normal as well. So again, this is in Crohn's disease, what you would see with an upper GI. Barium enema is putting contrast in through the rectum and trying to image the large intestine. Uses the same technique as the GI series, and again, it's less used with the CT, MRI, and colonoscopy available. So here's a barium enema, and this shows a herniation of the splenic flexure of the colon going up above the diaphragm. So that's an important finding to see, and again, this may or may not have been seen on a CT scan. If a GI doctor tried to do a colonoscopy, he would have been stuck there and said, what's going on? So they'd have to investigate that to see if it was a tumor or a stricture. In this case, it was a stricture. Again, these are abnormal barium enemas. They're using air in these as well. So after the patient has barium placed in their rectum, then air is put in as well. It's uncomfortable for the patient. It's not a pleasant test. And you can see there's an air fluid level here, so even though this x-ray is upright, they have the patient lying on their side. So this is more what looks like a normal large intestine, and these is an abnormal intestine related to Crohn's disease as well. Okay, so there's areas where there's scarring and there's normal areas. So that shows up in Crohn's disease. In these situations, a colonoscopy probably would have been fine, but it shows the barium enema and how that shows up in an air contrast. So this is an apple core lesion where you have, it looks like someone ate the outside of an apple. It's related to a cancerous growth. This is what polyps look like, and polyps in the cecum again, or this is actually cancer. Again, these are usually seen with other imaging. The final test is a positron emission tomography or a PET scan. It's also sometimes known as a SPECT scan because of the different cameras that are used. IV injection is put into the patient of a radionucleotide. It's 18-fluoro-2-deoxyglucose. So it's a kind of radioactive glucose. They call it FDG for short. So the way it works is cancer cells have a higher metabolism, and so this glucose gets taken up more rapidly by the cancer cells or any cells that have a high metabolic rate. And so then it shows up on the scan as an increased uptake. They have these different detector arrays that detect the radionucleotide. This is a very fast degrading nucleotide, so you're not walking around, or the patient's not walking around radioactive for days and weeks. It dissipates in hours. The axial views are taken, and then these images are shown recreated. So here's a PET scan of the liver, and these are metastases secondary to left breast cancer. So there's the cancer here. You can see it tracking into their lymph nodes. And they've got these large lesions in the liver. Now, initially, it will show up in the bladder and in the heart because it's going through the circulation. So it doesn't necessarily mean cancer of the bladder, although that lesion there looks suspicious. Here's a color-enhanced PET scan, and again, uptake into the heart, which is normal, but they've got lymph node involvement all the way along here. Looks like the kidney or liver here, perhaps. And this is a PET scan, CT scan. Sometimes they do a combination of PET scan and MRI. So you get an idea of the image related to the PET scan, and they overlay that, and they color enhance it. So they've got some lesions here in the mediastinum. Again, the heart has an increased uptake. Looks like liver here. This looks like spleen. And again, the bladder. And I'm not sure what's going on here, but there's some increased uptake there. It could even be a muscle strain. There are false positives that are related to it, but again, it gives you one more imaging to help you make the diagnosis. So it increases rheumatoid arthritis, tuberculosis, fungal infections, pneumonia. Empyema is a localized infection. It's an abscess in the lung, drug toxicity, and sarcoidosis. Fractures will increase it. Even osteoarthritis, that can have an increase, that can show an increase there. Radiation to the lungs. So that's it, and I hope that was helpful. I will answer any questions in class, and then we'll do a Jeopardy fun activity in class.